Perils of prescription writing. Prescriptions are the entryway to various pharmaceutical remedies for multiple health concerns and are crucial in today's healthcare system for alleviating diseases, associated signs and symptoms, and enhancing general health. However, the dangers of taking prescription drugs remain a critical challenge that to be mitigated. It is crucial to recognize and comprehend the possible risks and difficulties associated with using pharmaceutical interventions and when patients entrust their health to them. Healthcare practitioners and medical providers must navigate this complicated terrain by balancing therapeutic advantages and unexpected complications. To discuss more about the perils of prescription writing and navigate through this dangerous terrain, we have with us Dr. Amitav Banerjee. Dr. Amitav Banerjee is presently Professor and Head Department of Community Medicine at Dr. D.Y. Patil Medical College, Pune. Dr. Amitav Banerjee served in the Indian Armed Forces from 1978 to 2005. He started working as a professor and subsequently as the head of Department of Community Medicine at Dr. D.Y. Patil Medical College, Pune. Dr. Banerjee has published more than 100 papers in national and international journals and has undertaken several research projects. He has also delivered many keynote addresses at national and international conferences. Dr. Amitav Banerjee has a distinguished research career spanning over 4 decades. His substantial body of work encompasses critical investigations into epidemics, including typhoid, hepatitis, respiratory infections, and pneumonia, and has been recently recognized among the top 2% scientists around the world in the Stanford University rankings of 2023. It's an honor to have you with us today, sir. You may please share your screen and begin your presentation.
Good evening, everyone. It's my pleasure to present a talk on Doplexus on prescription perils. This is to commemorate this year's patient safety slogan. That is to raise the patient's voice. So the background is something like this: that there is an increase in use of pharma products. Lifestyle is becoming more passive. People prefer quick fix solutions rather than actively improving their health. And due to change in nature of jobs, we are having more sedentary lifestyle. Most of the time we are spending at our desk. Then also with social changes, we are having and market forces, we are having a fast food culture. Many times we order food rather than cook them at home. Then public health challenges. There is cumulative effects of large number of environmental changes. Like the environment is not very conducive for walking, for cycling, for physical activity. Environment is not very conducive or time constraints are there in modern lifestyle for cooking. So we have fast food. Then, of course, as I said, occupational changes. Most of the work is becoming sedentary. And ultimately, to get out of this nexus of adverse effects of over drugging, over prescription, and a sedentary lifestyle, we require a holistic approach. These will be the scope of my talk today. So this is how the things are, the trends. Like on the right side, you will find a figure. There are two windows. One is for lifestyle changes and other is for pills and surgery. So people are queuing up for pills and surgery rather than going for lifestyle changes. And even doctors who do not prescribe, sometimes they may become, who do not prescribe pill for every ill, they may not be very popular and people will change their practitioner because there is a overrating of the miracles. Medicine has done a lot of miracles, there is no doubt about it, but the marketing in the medical practice is also picking up. So there is many things are hyped and there is polypharmacy and these are the convenience. Towards convenience, people are moving. Historical approaches, traditionally obesity was approached by control of diet and physical activity. So now there are surgical alternatives have come, like bariatric surgery, and of course now there are medications, anti-obesity drugs. They are in selected cases, definitely bariatric surgery is indicated in selected cases, and of course in some selected cases, according to the endocrinologist, some anti-obesity drugs also may do benefit. But across the board, people may be tempted to go for these surgery and anti-obesity drugs rather than take time out for physical activity and dietary modifications. Because on one hand, the fast food and other market forces are in play in the food industry, and market forces are also in play to promote anti-obesity drugs and to promote surgery. So these all combine to make people opt for medical intervention, pharmacological interventions rather than lifestyle interventions. And the market for anti-obesity drugs is projected to be more than $77 billion by 2030. And as we have seen from the ecological data, from geographical distribution of obesity, as on today, the Western countries like USA, Europe, and other developed countries, the overweight percentage is almost uh, 60%. And Asian and African countries, it is around 20%. So they are three times more obese than or Asian and African countries. But even in Asian countries like in India, the affluent middle class is soon catching up with the Western countries in patterns of overweight and obesity. So as on today, even in India, the middle class, the obesity may be, the overweight may be coming nearer to the Western. And as economy develops further, we also may fast reach the obesity levels of the Western countries with the associated conditions like diabetes. Already we are known as the diabetes capital of the world, hypertension, ischemic heart disease, and all this will be requiring more and more prescriptions in the way of anti-obesity drugs and all, rather than lifestyle changes. So this is the challenge we have got. As on today, we may be having a window of opportunity, but if the anti-obesity drugs and other interventions they become more popular, so the cost also goes up and the side effects also goes up. So we have to make a balance. As I said, these anti-obesity drugs or bariatric surgery may be of use in selected cases, but not for the all who could be better benefited by, firstly, by prevention, primary prevention, not to get obese in the first place, indulge in some physical activity daily, indulge in prudent diet, and a holistic approach rather than going and waiting for drugs and surgery. So, medications, as I said, they are miracles, they are potent tools, but they are effective when used judiciously and in consultation with the patients. Here, as I said, the theme is to raise the patient's voice. So, we have to make the patients equally aware and involved in the decision making. And we have to communicate the risk benefit to the patient for particular drug. The topic, as I said, is prescription perils. So each drug has got benefit and each drug may have side effects also. So the ancient Chinese philosopher Sun Tzu said that one should know both the advantages as well as the disadvantages of a strong weapon. Drug is a strong weapon. So one who does not know the disadvantage of a strong weapon cannot use the advantage to full potential. So modern medicine is a very powerful weapon. So we have to be very careful, understand the side effects and explain to the patients. And then only we get the best out of it. medical establishment has been criticized because of this over-dependence on intervention and drugs. There have been some critics who have highlighted the medical establishment as a significant threat to health because the drug-induced conditions, deaths, adverse reactions, iatrogenesis, which is known as iatrogenesis. Iatro means doctor and genesis means given by doctor. So iatrogenic conditions cause the fourth largest cause of death and illness. That has become one of the threat to health. So some critics of modern medicine are saying that medicine itself has become a threat to health. So we have to check and we have to introspect. So this underscores the potential harm when medications are not used with caution and expertise. So double-edged nature, medicine which have a double-edged nature and need for caution, the importance of balance and importance of involving the patient. As I said, that the patient sometimes expects too much from medication. If a particular doctor does not give a medication, that patient changes the doctor. So therefore, patient education is perhaps more important than education or as important as education the medical professionals. So this history of iatrogenesis, iatrogenesis or drug interactions or drug adverse events are as old as medicine itself. In fact, some ancient cultures, they had very strict punishment for iatrogenesis. They sometimes cut off the hands of surgeons if the patient died. So of course that was barbaric. But and in the 1960s and 70s, Ivan Illich wrote a very book which became very famous, known as Medical Nemesis: The Limits to Medicine or Expropriation of Health. Illich defined iatrogenesis at three levels: clinical iatrogenesis, injury done to patients by ineffective and unsafe or wrong treatments. He described the need for evidence-based medicine 20 years before the term was coined. Evidence-based medicine came into vogue somewhere in the 1990s. In 1972, he wrote a book where he said that each intervention or medicine should have an evidence base rather than just giving blindly. Then social iatrogenesis, he says the medicalization of physiological conditions. Like we had one example of hormone replacement therapy. Menopause is sometimes some selected cases may require some treatment for controlling the symptoms of menopause. But the hormone replacement therapy became very popular, which was something like medicalization of natural physiology, and it was perhaps prescribed across the board to all menopausal women and subsequently found to have some side effects. So even that is called social iatrogenesis, when you medicalize even normal natural course of health or physiological conditions which are physiological and part of say aging process or part of some stress. You have some physiology of stress or some transient conditions and you want medications for that. Like you are under stress, you may anxiety and all, if you are facing an examination or if you are facing a crisis. So many times some sort of counseling, some sort of medication introspection can control the stress perhaps, but some there may be a tendency to go for the sleeping pill or a quick anti-anxiety drugs because the marketing forces are there. So that stress is normal and there are ways by which without medication one can control stress by meditation, counseling, or even taking a physical activity. Some exercise can relieve stress. So instead of that, you go for social medication. That becomes the social culture has been created that even this normal ups and downs in life, you require medication. That is social iatrogenesis. Then there are some cultural iatrogenesis changes now. Like in elderly patient, the end of life stage sometime, there is a tendency to give life support and all and to fight with our immortality. So rather to fight with our mortality. That human beings, the physiology, there is a lifespan and there is a death, which is a natural process. So medicalization of death, trying to drag life when the quality of life is not there, that is cultural iatrogenesis. That end stage care. It is too expensive. If you see nowadays the aging population in the West, there are too much of interventions which at times the elderly may and even the family members may like a peaceful passing through rather than in a isolated hospital bed or in the ICU. So these all require a good balance between the doctor, patient, and the relatives. What they prefer, what the patient prefers. So because mostly physiological or naturally elderly, at the end of his life would be like to pass uh, among family and friends rather than isolated in a hospital bed. So these have to be. So this Ivan Illich book became quite popular. Of course, he has gone to extremes, but it requires some introspection. There are points for introspection on over medicalization. Then sometimes this rapid introduction of drugs, the very famous in the 50s and 60s was the thalidomide disaster. This is a drug which was again medicalization of life. That is, the pregnant woman took thalidomide on a large scale because it was promoted as a anti-emetic or as a sedative in first trimester of pregnancy. And this nausea is again a physiological process in the first trimester. And subsequently, large number of newborns had phocomelia, that is absence of limbs and other congenital abnormalities born to mothers who had taken thalidomide. So this became a major scandal, and so this is a historical alert that particularly in pregnant women, untested drugs should not be, particularly in first trimester when the fetus is developing. Any adverse events affects the fetus, which can cause permanent, like congenital anomalies. Like in thalidomide, there was loss of limbs. Without limbs, children were born, phocomelia. So this thalidomide scandal was a wake-up call for the medical profession and for the pharmaceutical industry that we should be very cautious and follow the Hippocrates oath, which says, first do no harm, particularly in pregnant women and children. These are the new drugs. As I said, there's a huge market for new drugs. There are two graphs. One is on the blue graph on the left and orange yellow on the right. Actually, this is not to scale, but what it is showing is from 2000 to 2017, 2001 to 2017. On the left are the new drugs approved by the FDA USA. And what is approved in the West, it comes in our country also. Uh, so new drugs, it is almost a yearly addition of new drugs. And every new drugs require a proper pharmacovigilance. Pharmacovigilance is after the drug is introduced in the market, you should have a warning system, a surveillance system to find out any adverse effect. So the more drugs are there, the more difficult it is to follow all the drugs and relate the side effects to a particular drug. So anyway, the left side is the last, let us say, in 2017, 40, about 40 plus new drugs were introduced. And on the right side are the new drugs for orphan drugs. What are orphan drugs? Orphan drugs are there for diseases which affect very little, less number of people, less than 2 lakh people. Mostly like neglected tropical disease and diseases of poverty. So left side are the new drugs which are progressing, which are being introduced in the market at a very rapid pace, and the neglected diseases, the drug discovery, drug research is much less because new drugs are for the people of affluence, for disease of affluence. Like I said, anti-obesity drugs expected to have a 17 billion market. For diseases like tuberculosis, malaria, filariasis, we continue with old drugs. Once in 20 years or 30 years, we get a new drug. So this is the challenge we have, the affluence and the disease of poverty. Adverse reaction, as iatrogenesis, as I said, is an important cause of death. And meta-analysis published in JAMA, it said that the adverse drug reaction and fatal adverse drug reaction to be the fourth and sixth leading cause of death in USA, 1994, and adverse drug reaction is an important clinical issue. So sometimes different years, it was from fourth to sixth highest cause of death from drug itself. So it's an important clinical issue. So we require safety at all levels. We require safety at the doctor-patient interaction, where the patient and doctor, the doctor duty is to educate the patients of the potential harm and potential benefit, and try to promote lifestyle first and drugs later. So the modern trend is just the opposite. You just prescribe the drug. There are too many patients also. So there is no time for counseling. That can be one reason. And second is the promotion, high scale promotion of drugs. And third can be the patient expectation also. The patient thinks that drug will do magic. So this increases the consumption. It's not only doctors, its patients are equally responsible. I know my own relative, she had mild diabetes. So I said, Ki, why you are taking too much of sugar and sweet? She said, I go to the doctors. It is the doctor's duty to control my blood sugar. If I can control my blood sugar by lifestyle, what is the doctor doing? So this is the attitude, that passivity, that it is the doctor's role or the medication's role to control me. I have to enjoy life. So this has to change. The global burden of disease shows a 53% increase in deaths due to adverse effects of medical treatment from 93 from almost 93,500 in 1990 to almost 1,40,000 in 2013. You see the huge increase. So from 1990 to 2013, there is an increase of almost 60,000 deaths from adverse drug reaction. As because newer and newer drugs are entering the market, and there is resources are not there, infrastructure is not there for proper pharmacovigilance, reporting of adverse reactions, and so on. And in India, from a tertiary care hospital, 3.5% severe adverse reaction and 0.22% fatal adverse drug reaction. This is just from a tertiary care hospital. Other places may not be recorded also. It was estimated that around 20 million adverse events from treatment had occurred globally. So these are some of the concerning data. The substandard drugs, particularly in developing countries like India, we are faced with poor control of quality of drugs. So, I mean, certain events, recent events have also emphasized this. So we require certain measures. The concerns and myths of effective drug regulation. Drug regulation in India is very, very primitive, one can say. And this was brought to notice with the DEG. DEG is diethyl glycol associated child fatalities from cough syrup. Highlights the prevailing myth of effective drug regulation in India. Children death is very, very tragic, particularly from something like cough syrup, which is consumed so frequently. Then renal damage, as you know, in Gambia, in Uzbekistan, last year there were deaths of children from cough syrup due to damage to the kidney. It can damage the liver also. The more concern is that these may be the tip of the iceberg, because if there is severe damage, there is immediate death, but there may be damage to others also, which may not have caused immediate death. Perhaps it can cause long-term harm to the liver and kidneys. So individuals at risk of exposure to substandard medications, potential for long-term damage to vital organs, particularly kidneys and livers. All drugs have to pass through kidney and liver. And overall significance, recent events significant impact India's reputation as the pharmacy of the world. India is one of the largest drug exporters. So it has to affect our economy also. If our reputation, it affects the our patients' health also, Indians, as well as it affects the global. If we are pharmacy of the world, humanity, large percentage of humanity health is at stake. So India requires drug regulation of high standards. So this underscores the need for. So cough syrup tragedy, as I said, specific in 2022, October, WHO issued an alert, cough syrup manufactured in India. 65 children died in Gambia and 19 children in Uzbekistan due to diethyl glycol. And in the recent past also, diethyl glycol poisoning have occurred. In latest, if you go from down upwards, Alamnagar 2019, 12 children suffered same fate, Gurgaon 1998. So there have been frequent cases of diethyl glycol, which is a solvent, which is an industrial solvent, which is not to be mixed with cough syrup, but by sometimes spurious drugs or sometimes by accident, if it gets mixed, it can be fatal. Other countries control it by strict drug regulation. We are still struggling with it. So this is an important issue. These are indicators that all is not well without drug regulation. Then other gray area in our country is pharmacovigilance. That is the after, like when a new drug is introduced, it goes through phases of clinical trials. Phase 1 trial where they do in some animal model. Phase 2 trial, small number of patients. Phase 3 trial are the randomized control trial at the population, large, very large sample. And after the phase 3 trial is cleared, it is marketed. Once it is marketed, it is continues as a phase 4 trial. It's not a trial, but it is continue till it is in the market. Any adverse events should be recorded and reported. That is called pharmacovigilance. So this is a very gray area. Even in Western countries also less than 1 to 10% only of adverse events are reported in Western countries. So you can imagine in our country, which is very large, and where large number of manufacturers of different qualities. So this drug regulation, we have limited drug inspectors. We have got archaic laws. We have got a lot of loopholes in our drug regulatory system. So this is the upstream. So to have a safe prescription, no harm from drugs, you require a downstream cleaning as well as upstream cleaning. If the water coming from upstream is dirty, no amount of downstream cleaning will save the patient. So first is patient should take it prudently, doctor should prescribe prudently, and the quality of drug is upstream. That is the manufacturing process, the inspection process, and the distribution process. So we have got at all levels, we have got weak links. And this is some of the challenges we have to face. So pharmacovigilance is that everybody has to report the adverse drug, and there should be a mechanism to report the adverse drug, any side effects. So awareness is not, the patient may not attribute it to the drug. Doctor may also pass it off as coincidental. Any adverse event should be reported to a agency, pharmacovigilance. Each medical college, each hospital has a pharmacovigilance cell. It has a box where you can drop your feedback. This awareness is not there among physicians and even among patients. The market challenges. Other challenge is the polypharmacies, because one particularly elderly, they are having now super specialty. They are taking medications from multiple doctors at a time. Earlier times, there was one family physician, he knew what is the patient taking. Now, elderly patient may go to a cardiologist for his heart problem, for a diabetologist for his diabetes problem, for an orthopedician for his joint problem, and ENT. So at any time, he may be seeing 3 or 4 doctors, and each doctor will be prescribing something, not knowing what the other doctor is prescribing. So there may be drug interaction, and elderly people have got compromised renal kidney function, compromised hepatic function, and they are the ones who are getting the polypharmacy. So this is again a challenge. So it is a duty, it is awareness is required at all specialist doctors and super specialist doctors, of course, that they should ask the patient what other medication the patient is taking, and they should know something about the drug interaction, if any. And this compromises the patient safety, and the awareness is required at all levels. The patient also has to be made aware to tell each doctor what he is taking from the other doctor. Nowadays, another problem is now there is a too much proportion. There is alternative medicines like Ayurveda, homeopathy, Unani. They are also coming in the market. I mean, they are also in practice now, and they are coming to prominence. And the patient may be taking some Ayurveda product, they may be taking some Unani product, homeopathy product. So they may not tell to the doctor of modern medicine. Those are also important. I have seen cases of heavy metal poisoning from these traditional healers, and causing dermatitis or even renal failure. So these are challenges. In our country, it is beyond polypharmacy. There are different systems of medicine. So some sort of coordination is required, and their products do not have a very good regulation also. At least modern medication, we have got some regulations. They are not even having a mature medica. So these are the challenges we have to cope with. So national drug surveys have found that up to 3 to 10% of drugs are not of standard quality, 3 to 10%. And 50% of antibiotics have been found not of standard quality. You see, we are always saying that we are developing drug resistance, but one of the causes is, of course, misuse of antibiotics. One of the causes of drug resistance would be substandard antibiotics, which will promote drug resistant strains. So, and less than 1%, 0.1 to 1% of drugs are tested at random for quality. So, because of lack of resources, lack of laboratories for testing drugs to the volume of year, and we do not have a legal mechanism is also weak to recall drugs which are substandard. Some state regulators have also raised the issue the only way to any sort of information from other states by initiating criminal action against them. That's how bad the task of coordination is. So each state has got its own jurisdiction. So, and center state, again, there are different channels. So it becomes a lot of red tape, and a lot of action to quality control gets delayed. So this is one book, very good book by The Truth Pill. It became quite famous and, of course, controversial at the same time. Dinesh Thakur and Prashant Reddy. So the drug regulations in India, they say, of course, they have gone to the extreme and calling it a myth. Authors of the book have presented how fragmented the regulatory system for drugs are in our country. Fragmented in the sense there are different states. There are so many states, and the center state, the responsibilities are not very clear cut. The Drugs and Cosmetic Act is very old, 1940, a colonial regulation. At amended several times, regulators are present state and national level for safety and efficacy. Still, so on paper, they are to ensure safety and efficacy, but they do not have enough resources or enough manpower to meet the challenge. Examples of azithromycin 200 milligram level containing only 12%. Azithromycin is an important antibiotic, and only 12% active ingredient was found in some samples. So if a patient is having serious bacterial infection and the doctor is prescribing, the upstream, as I said, no. The errors can be downstream, doctor-patient, over prescription. But if the drug from the upstream is coming low standard, it's a major. The doctor also doesn't cure his patient. The patient also, if serious conditions, may die also. In a random check of authorities, 53 samples failed quality tests and 3 were found to be spurious. So spurious, Central Drug Standard Control Organization. There is a CDSCO at the center. It is high time that we have greater transparency in the drug regulation and a better framework. Greater accountability is required, and accepting that the problem exists will be the first step towards the goal. So, this book is a very exhaustive book. It has about many chapters about the drug quality in India, what are the lacunae, different court judgments, how difficult it is to really and ensure good quality by good deterrence and punishment. Actually, even life imprisonment is part of the punishment if there is a spurious drug. And the authors have noted there are hardly any convictions. There are hardly any convictions, and sometimes the conviction is the punishment is very little. So, needs for regulatory reforms and patient safety. Emphasis on patient autonomy. Patients should have a choice in consultation with the doctor which drug is best for him. It takes time, of course. Downstream versus upstream emphasis I have already mentioned. Downstream is the doctor-patient relationship. Upstream is the manufacture, storage, and distribution systems. Doctor-patient level measures what can be done. Meaningful discussion about potential risk benefit can mitigate iatrogenesis. Patient education promotes diet and lifestyle modification, reducing the need for medication in chronic conditions. So this is because we are going to have with increasing lifespan, sedentary life, and food, unhealthy food. These are the major problems we are going to face, and we have to promote a healthy lifestyle. Pharmacovigilance awareness. Adverse drug effects are not recognized in Western countries, less than 10% or even 1% in some countries. So, all country also we can make a guess, it must be 1%. Quality control and drug life cycle we have already discussed. We require improvement in the laws of drug regulations. Chronic condition management focus should be on lifetime modification, obesity, diabetes, hypertension. They may require drugs, they do require drugs, but with lifestyle, the requirement of drugs can be made less. Limitations and drug regulations are, as I have already mentioned. Current structure, just a very brief overview that there is a central drug control organization and 36 state level agencies which have the regulatory framework. And new drugs are cleared by the Central Drug Control Organization through clinical trials and imported medicines. State authorities are licensing for manufacturing, sale, and distribution. So that was the drug passes here. Then historical challenges, suffering of responsibilities is independence, leading to poorly defined roles. So in this, the state and center, they are poorly defined role. Who is responsible for what and who will give the punishment. Interstate jurisdiction ambiguities contribute to regulatory gaps. So, look, one state manufactures the drug is manufactured in one state and it has been formed in other state. So then the interstate here comes. What is who will investigate, punish, and quality control? Operation understanding the regulatory agencies insufficient lab facilities for quality checks. The lab they require very sophisticated labs, and near drugs are coming. So it is a very intensive, technology intensive process. So near labs, the turnover of drugs in a large country and export burden also, that we do not have the sufficient human resource as well as the lab resource. Consequences, inadequate regulation and lack of uniform drug quality across India, and substandard and adulterated drugs. Of course, substandard can be poor quality, adulterated can be harmful also. And of course, substandard can also be harmful. If antibiotic doesn't work, the patient may die of severe infection. Urgent reforms are needed on these. Emphasis on quality control and patient safety should be top priorities. Comprehensive debate involving stakeholders essential for effective reforms. You have to involve all the stakeholders, which includes the patients and their families also. Then only the policy changes come. Then only the felt need comes. Then stakeholder involvement, patient, families, civic society, parliamentary bioethics, then global reputation, India's global reputation and export. It affects our reputation as well as economy. So these are some of the references, and I think I have finished. There are certain things which had come, which became quite last year. There was a Jan Viswas bill. I have not mentioned it, so I think we can finish the slides. So I can just mention them offhand. So, Sheetal, we can come back. Yes, there were three issues which came up last year. One was the National Medical Council passed an order that all practitioners of modern medicine should write generic. They should prescribe generic drugs. So that became quite controversial because in India, generic drugs have got very variable quality. So ultimately, the IMA also protested and brought out that there is poor quality control. So that has been held in abeyance. Other is the Jan Viswas bill, which was passed last year, I think August or July or somewhere in September. That Jan Viswas bill is to promote business of manufacturing. So some of the penalties were Jan Viswas bill allowed for some of the penalties to be compounded, that is, paying a fine instead of going to prison. That also became quite debatable because, you see, as it is, we are not a manufacturer drug is found not of standard quality. Earlier, there was a deterrence of some prison term. So now he has the option, the manufacturer has an option of paying out instead of going to prison. So that was also debated. I think that became controversial that this will again make the quality control will be affected adversely. There is no deterrence because paying a fine is nothing for a manufacturer who is manufacturing large drug in bulk. Then the third, of course, it has not come out, but there were some groups who wanted to introduce the biosimilars. Biosimilars are drugs which are similar to the original drug. They are used in cancers and other chronic diseases, but they have a similar action, but they are different compounds. So there was a recommendation by certain groups to waive or to do away with the testing of efficacy and safety of these biosimilars coming from other countries. So that also, of course, it has not come, but that also was a cause of concern. So here, what it conveys is that there is a issue of cost because affordability. So when you have too much of quality control, stringent, the cost of drugs go up. And has to be a trade-off. I mean, but it should not be at the cost of patient safety. So this has to be conveyed to the patients and even common people. Everybody is a potential patient. That the quality is more important than the cost. So there sometimes the populist measures may be that everybody have access to cheap drugs. Everybody has. So the people feel that we are having cheap drugs. But education is required. It should be cheap, but not at the cost of quality, which can be hazardous to health. So that is the one thing which I wanted to say. Thank you. I think that's all I had to say. Any questions or any other points? I'm ready to discuss.
Thank you so much, Dr. Banerjee, for that very detailed presentation. It's been an eye-opener for most clinicians, and I'm sure our audience must have found that session very helpful. We do have a couple of questions for you today. The first question that we would like to ask you is, with the rise of antibiotic resistance, what guidelines do you prescribe to counter this global health issue?
Very important question. Actually, the problem is it is all at the downstream as well as the upstream. Upstream, as I said, if the antibiotic capsule is not containing adequate concentration, like azithromycin had only 12% of manufacturing defects, so it will promote antibiotic resistance. So that is, of course, quality control. So for that, you require very strict drug regulation because nowadays, most of the time you see in the newspapers and other things, they say doctors are overprescribing, people are self-medication, it is giving rise to antibiotic resistance. Of course, that is a major part, but there is also the quality also. That is one. Secondly is in our country, we have got a large type of practitioners. We have got the practitioners of modern medicines. We have got practitioners of Ayurveda, Ved, Hakim and other things, particularly in rural areas and suburbs. So most of them are also prescribing antibiotics. So this, I mean, though they are not supposed to, but they are prescribing. And even in government hospitals, we have got practitioners of alternative systems of medicine, they prescribe. So education is required to them. And of course, the self-medication is also there of antibiotics. And if you go to any chemist, you can see any patient comes and he or she can buy antibiotics over the counter. So that over the counter is not supposed to be, but in our country, it is just like they buy like kirane ke dukan se they buy anything. So that is I mean, it is something like nobody observes traffic rules. So this all this give rise to antibiotic resistance, misuse of antibiotics. Then also antibiotic resistance is not only human medicine; it is prescription in the poultry, prescription in the animals, veterinary medicine. So it's a very big issue actually. So everybody has to sit across the table. All stakeholders have to sit, and policies have to be made, and implementation. Like antibiotics should not be given by the pharmacist without a doctor's prescription. So all this it requires at many levels. And of course, at the hospital level or health center level, proper monitoring of the uh, blood reports and urine culture reports, blood culture reports of antibiotic sensitivity, because each year there may be the results from the bacteriology lab. They keep a record of the surveillance of what are the antibiotics to which a particular organism is sensitive and to which a particular organism has developed resistance. So that sharing of data is also very important.
Thank you for that response, sir. The second question that we have is, what role do electronic health records play in minimizing prescription errors, and what are some of the limitations in this regard?
It's good. There is a there are pluses and minuses of electronic health records. Of course, one of the criticism is that it takes away from the doctor-patient interaction, because most of the time the doctor is looking at the health record and the patient eye contact is not there. Of course, having said that, of course, the doctor can have an assistant who can enter the record. And nowadays, with improvement in AI and technology, it may be the doctor may just have to speak and the electronic record may be updated. So, one thing good about the electronic health record, as far as proper prescription, rational prescription is concerned, that this record itself is an incentive for the doctor to be careful what he prescribes. Because if there is any adverse events later, the record is there. So it is for his rather safety as well as caution, the patient safety also. So, and secondly, he or she, the doctor and the patient, or he or she, can also go back electronically, retrieve the past medication or then any adverse events to a particular drug, any reaction or allergic reaction. So definitely, if used properly, this electronic health record can improve the prescription patterns and save prescription.
Thank you. Thank you for that answer. Moving on to the last question before we close this session. Could you also elaborate on the importance of patient education regarding their prescribed medications and how it can help mitigate potential perils associated with prescription writing?
Educated patients nowadays, and there is a Google doctor also. So patient, and then most of the marketing, the pharmaceutical industry has got a very large marketing sector. So there are miracles are promised. So patient expects miracles from drugs, and he or she expects patient to the doctor. Doctor should give newer and newer medication. Like even for pain, if I am a doctor, I give paracetamol to my wife. It is and then I take her to the orthopedic surgeon. It has happened with me. And he also prescribed paracetamol. She said, no, this orthopedic surgeon is not good because he is prescribing what I am prescribing. As it is, I am not good. घर का कोई doctor नहीं होता. And if the doctor, orthopedic surgeon also prescribes the same thing, she loses faith in the orthopedic surgeon. She wants to go to a better in the sense that another orthopedic surgeon will give the latest analgesic or something, which may be new, but we don't know how safe it is. So the patient education is important in the sense the patient should have a realistic expectation from the doctor. I mean, from the drug, and a patient should be told that the marketing forces, like any product, the marketing things may be over hyping the benefit of a particular medication, and the doctor also should be able to convince the patient. And you see, I was reading a book by a doctor who has written on this. I think it's an American, I'm for Abramson. He has done a lot of work on this. He says that sometimes by force he has to prescribe something to the patient when the patient demands that, not because he thinks it is good for the patient, because he rationalizes that if he doesn't prescribe it, the patient will change the doctor and the patient will go to another doctor who may prescribe something more harmful. So sometimes we feel, particularly with increasing education level, sometimes the patient may dictate the medication rather than the doctor, particularly with, as I said, with the Google and other coming. So it's a difficult thing. I mean, it requires a skill on the part of the doctor, personality. Most may not have, but with that, how to convince the patient that this medication is best for you or no medication is best for you. So it's a art which is difficult. We can't have any guideline 1, 2, 3, 4, but it has to be kept in mind depending on the patient's personality and the doctor's personality.
Thank you. Thank you so much, Dr. Banerjee, for those very detailed responses. It's been a pleasure listening to you. To all our audience members, thank you so much for your active participation in today's session. Until then, please take care. Thank you very much.